Most people think chronic pancreatitis is due to chronic alcohol consumption, but they think of it only as a consequence from binge drinking episodes. But you can have chronic pancreatitis simply because you have prolonged use of socially acceptable amounts of alcohol. It typically will present with chronic epigastric abdominal pain that radiates to the back, and it's partially relieved by sitting upward or if they lean forward. As far as duration, the pain doesn't stay, and patients can be intermittently pain-free for months to even a year. When you have progressive pancreatic inflammation in chronic pancreatitis, this causes non-reversible exocrine and endocrine functional damage. The other causes of chronic pancreatitis can be because of cystic fibrosis, but you'll tend to see these in children. You can also have it because of ductal obstruction due to some sort of malignancy or even stones. And another cause of chronic pancreatitis is if the patient has some type of autoimmune disease that is attacking the pancreas. The clinical presentation, like I said, has that chronic epigastric pain that has some pain-free intervals, but also the patients will have problems with absorption. So they may have steatorrhea or even weight loss. They may even present with diabetes. For laboratory results and imaging studies, you want to look for amylase and lipase, which can be normal in the setting of chronic pancreatitis, but it will be elevated in acute pancreatitis. Using a CT scan or MRCP can show calcifications, dilated ducts, and an enlarged pancreas. The typical treatment for patients with chronic pancreatitis is pain management. You obviously want alcohol or smoking cessation, and you want the patient to have frequent small meals. You can also help the patient with their malabsorption with pancreatic enzyme supplements. When looking for the best diagnostic study, especially for chronic pancreatitis, don't automatically pick serum lipase levels. Like I mentioned earlier, because chronic pancreatitis causes this fibrosis in a burned out pancreas, their levels can be normal or very just slightly elevated compared to acute pancreatitis. It's also incorrect to do an upper GI endoscopy because this is indicated for suspected peptic ulcer disease, gastritis or dysphagia, or hematemesis, but you can diagnose chronic pancreatitis without any invasive or endoscopic studies. How about if you suspect the patient has some sort of pancreatic cancer? Don't pick the serum cancer-associated antigen 19.9 levels, or the CA 19.9 levels. This is because it actually has limited sensitivity and specificity, and an abdominal CT is usually the first step if you suspect pancreatic cancer.